the World Massage Conference.
Hello and welcome to the World Massage Conference pre-conference series for the 2012 conference program. I'm your host, Eric Brown, and on behalf of my World Massage Conference partners, Scott Dartnell and Melanie Hayden, I want to welcome everyone on board for this presentation with noted massage expert Til Luchau, who's going to be talking about working with whiplash. Now, whiplash can be made better or worse with hands-on body work. I want to welcome you to join Advanced Training faculty member and certified advanced rolfer Til Luchau as he presents ways to safely and effectively work with this complicated but common injury pattern. This engaging presentation will expand and deepen your skills. You'll gain a clear framework for understanding the structural and neurological effects of whiplash, as well as practical tips and specific suggestions for hands-on approaches that can be incorporated into your existing work right away. Our speaker tonight, Til Luchau, is a lead instructor and the director of AdvancedTrainings.com. As a certified advanced rolfer, Til is a faculty member and coordinator of the Rolf Institute's Foundation of Rolfing Structural Integration Program, where he is the originator of Skillful Touch Bodywork, the Rolf Institute's own training and practice modality. His regular myofascial techniques column appears in Massage and Bodywork magazine, and his articles have been published in peer-reviewed and technical journals in Australia, Canada, and the USA. He has trained thousands of practitioners in his popular courses at schools and centers in over a dozen countries on 5 continents. Last time we spoke with Til, I believe, Til, you were talking to us from a hotel room in Spain for the Spring World Massage Conference.
I remember that.
And
yeah.
now we're calling you in around Boulder, Colorado. Correct?
Yes, just outside of Boulder. Mm-hmm.
Fantastic. Now, before we get started with your broadcast, Til, I just want to thank our sponsors who allow us to bring this incredible lineup of educators into your homes and offices. We want to thank our global sponsor, Massage Envy. Massage Envy is the leading employer of massage therapists in the United States. To discover the benefits of choosing Massage Envy as your career, visit their website at www.massageenvycareers.com. And we'd also like to thank all our daily sponsors, Massage Warehouse, Massage Today, Bon Vital, BioFreeze, Upledger Institute, Massage and Bodywork magazine, and our education sponsor, Associated Bodywork and Massage Professionals. So without any further ado, we bring you one of the stars of the massage world, Til Luchau, who's going to be talking about working with whiplash. Again, Til will be taking questions from you, the listeners, on this broadcast. So take a look for the blue Ask Question button that you'll see below the broadcast window. If you have any questions about whiplash or neck pain, enter them in the pop-up box, and we'll answer as many of those as possible before the end of the broadcast. I also want to welcome you to log into the chat room, because after the formal presentation is over, we're going to show some video Til has generously contributed, and you'll get to talk one-on-one with Til in that chat room. Now, Til, I'm going to hand the mic over to you and let you get started.
Thanks, Eric. And I want to thank you, and I want to thank Scott and Melanie, too, for making this available. It's a great chance to talk with people from all over, and it's fun to hear both afterwards in the chat room and in the emails and on Facebook the kind of conversations or questions these start. And let's just jump right in. I want to give you a couple of suggestions about getting the most out of your time with us tonight. First suggestion, really engage your body. This can be a very disembodied medium. It's easy to forget about our bodies, but here, given that most of us are body therapists on the call, really want to ask you to remember the fact that you are a body, have a body, and that you can do things like move or stand or check in with your own body, breath, etc., just as a way to learn and enjoy the process even more. Engage your mind. Take notes, ask questions, write down things you agree with, disagree with, want to know more about. And again, Eric's mentioned you can chat. You can send in your questions meanwhile while we're talking, but also at the end, and then I'll have a chance to interact with you about those. And then finally, avoid multitasking. The computer is a natural medium for getting a lot of things done, including your email or your Facebook, or you could be listening to the audio and doing things. Now, you'll get a lot more of the time together if you give this your primary attention, if you're able to actually follow what we're saying and chart along with the slides, both visually and auditorily, and finding these things in your own body. There are some optional quiz questions for CE credit. I believe that you answer those through the World Massage Conference site. I'll probably contact you or have ways for you to do that afterwards. Later, you can also answer them on our site, advanced-trainings.com/WMC12W is a special page we've created for those of you on this call that'll take you to various links on our site and various offers there. But I'll go over these quickly. According to our model, what's the primary goal in working with hot whiplash? And these are going to be multiple choice questions. And, of course, I will define what hot whiplash means. And according to the model I'm going to present, muscle spasm is commonly seen in which? Hot or cold whiplash? So listen for that. Which of the following are not yellow light signs of hot whiplash? There'll be a multiple choice question there. And direct or deep fascial work involving pressure is most appropriate in which? Hot or cold whiplash? And then number 5, which of these was not a tip from our instructors about working with whiplash? Signs of nervous system activation. I want to review those quickly because we're going to look at whiplash as both a structural phenomenon involving the tissues of the body and a neurological phenomenon involving the nervous system. And just most of you know these kind of fight or flight signs, but just quickly, they include things like elevated heart rate, sweating, shallow, rapid breathing, increased alertness, anxiousness, cold hands, sleeplessness, etc. Now, I'm telling you this in order to give you a context to watch your own reactions as we go through the slides tonight, because we have different pictures. Some of them are funny, some are serious, some are technical, some are more light. And I'm going to ask you to watch your own activation, your own nervous system activation as we go through these. For instance, what happens in your body, just check that out for yourself, what happens in your body if you take a look at this picture. And the picture I'm looking at is of a crash test dummy sitting in a car in a kind of neutral position. And what happens as we scroll through a little bit and something's happened, the crash test dummy is being thrown back against the seat. So you can watch the picture and notice any reactions of your own that might happen. So in the rebound phase, the dummy's being thrown forward and the head's being forced into flexion, head and neck into flexion. And then back to neutral. So I'm going to go back through those again rather rapidly. And you just notice any autonomic reactions of your own. Some of us may or may not have them. Those of us who do, you can just notice that. Sometimes just seeing a crash test dummy thrown around will have a response in our body, especially if we've been through something like this. Whiplash happens sometimes just from remembering. Well, the whiplash doesn't happen, but the autonomic reaction happens just from remembering. Now I'm going to go through a list of possible effects from whiplash here, and we'll put them in an order, and then later I'll talk about the logic to the order. But I want to say this doesn't just apply to crash test dummies and accidents. These kind of symptoms apply to any traumatic event, you could say, or things involving physical trauma, but there's probably also connections out into other kinds of trauma as well. You can watch for those as well. So in a physical trauma, or like a whiplash, you have tissue damage. The tissues get injured in different ways, and we will look at that. Here's a picture of some tissue being injured, where there's a physical impact sometimes with a whiplash or a fall or a blow. And the tissue has to adapt to that, and sometimes the tissue actually gets harmed. For instance, when your head gets thrown backwards into hyperextension, the tissues, the fascias of both the muscles and the structural supports can be overstretched along the front side of the neck, both deep in the neck and the prevertebral muscles, and say it's sternocleidomastoid, or the superficial fascias outside around the neck. When the head gets thrown forward into the flexion phase, or if you get, say, hit from the front or have an impact from the front, the head will be thrown forward, and that could cause direct tissue damage to the tissues along the back of the neck. Pretty simple ideas. Of course, there's much bigger things happening in the body. It's bigger chains of force and impact and strain that are being transmitted. But just on the most local level, these are some of the tissues that could be damaged as the head gets thrown around. Now, dialing it down into the collagen of these tissues, some interesting things happen. A collagen molecule is a helix. It's a chains of amino acids that are chemically bound together in this helical arrangement, and that gives them some stretch and some spring. And in a normal elongation, they stretch a little bit and they bounce back. When they've been overly stretched, when the tissues have been torn or they've gotten to the point of not being able to adapt anymore, the amino acid chains actually become unlocked from one another and they break free from each other. And that means they don't have the same recoil either. They're not able to stretch back. You can think of a piece of elastic that's been overstretched or something that's lost its ability to recoil. That's what happens to tissues on a very local level when they've been damaged from whiplash type injury. That's right down at the collagen level. Those effects, as I mentioned, go all the way through the body. So even if it is just your head and neck that get moved around, many people will feel the effects of that all through their system, because these relationships, as this diagram shows, in some front-back arrangements go all the way down and help determine our alignment, our balance, the space in our body. So if tissues don't have the same resilience or spring, they will affect things all the way through. Now, whiplashes have been observed to happen at speeds in a car as low as 5 miles per hour, so sometimes it doesn't take much. On the other hand, people can go through a pretty violent accident and not have many effects, so it's not really proportional to the amount of speed, you could say, but it's funny, unpredictable patterns that go through the body of tissue damage. And one of the ways to start to understand that is harmonics. This is a diagram of a string, say a guitar string, vibrating. And on the left, you can see the whole entire string vibrating with one length, as one piece. And then as it's doing that, it's also vibrating in fractions. So half of it is vibrating at a time. It's forming like that S shape in the middle. And then the thirds, it has a third harmonic, all the way down to very small fractions of that string are vibrating at the same time. Something like that happens in the body probably too. So when we get whipped or when we get jarred, there's a large wave that goes, or a large impulse that goes through our body, and then there are crossover points. And it's pretty common for people that have had a jarring injury to their head and neck to have some soreness right in their mid-back, right at that crossover point where that half harmonic would be. Maybe that's an explanation for it. I don't know. That happened to me a couple years ago. I was skiing with my son, and all of a sudden I realized, he was about 11, 12 at the time, all of a sudden I realized I wasn't having to wait for him anymore. He was keeping up, and I was skiing just at my normal speed, and there he was, maybe even pulling ahead of me. And I looked over at him, and I gave him a big grin, and right at that instant I caught an edge on my ski and went down pretty hard. It was pretty good fall. And unfortunately I had a helmet on, but I did slam my head down and whip my head around, and the place I was sore later, even though it was my head that got whipped around, was my mid-back, and from that kind of whipping down onto the snow action. So that's one way that tissue damage happens in the body, and one way that can happen both locally and non-locally when there's a jarring or whiplash type injury. Another effect of whiplash is instability and weakness. Now, that instability or weakness can be a result of the tissue damage itself. Of course, tissue that's been damaged, when the collagen molecules have been overstretched, they're less stable. The muscles become more weak. But there are other things involved too, like say if nerves get stretched. Common was a lateral whiplash, getting hit from the side. When the head gets thrown off to the side, the brachial plexus or cervical nerves can get stretched. And the connective tissue of the nerves can actually get damaged. The nerves are largely connective tissue. There are axons within wrappings upon wrappings of connective tissue. So the connective tissue itself can get stretched and unlocked, and begin to scar, as we've seen in other kinds of connective tissue, or the blood supply can get disrupted. This is showing how nerves that are meant to stretch have a blood supply that has these little pigtail kinks in it. It's a picture from Baral's book on the nerves. And these tributary arteries stretch along with the nerve unless it gets overstretched, and then they can get occluded or even torn, and the nerve can lose some of its nourishment and be less happy. And then, of course, we have pain and other kinds of nerve symptoms. There are other ways that instability and weakness can come. And another one is through the dissociation of postural reflexes. The Golgi tendon response is one example. This is a diagram of that. It works in synchrony with a muscle spindle response, and the two of those together keep our muscles toned appropriately and relaxed appropriately to be able to stand and move. And they're a little bit analogous to, say, an accelerator and a brake, those two reflexes. One is telling the muscle to be less toned. It's an inhibitory response, and the other is telling the muscle to be more sensitive or more toned, an excitatory response. Those get dissociated from each other. They get confused, and they don't work very well together after some tissue injury, after whiplash. And it's a bit like driving around with one foot on the brake and one foot on the accelerator, or sometimes neither foot on either one. But these different reflexes that work to coordinate our movement stop being able to coordinate as well, and we get weak and we get unstable. So another effective whiplash on our continuum here is muscle spasm. Now, these might be stages or steps. You could think about the ordering that way, too. There may be other ways that the logic of this order makes sense to you, but these might be chronological. Let's see as we go through it if that fits. But muscle spasm is another effect of whiplash, and that's an attempt of the muscles to stabilize the stability that's been lost often through tissue damage or through those loss of postural control through the reflexes. So the muscles get tight to try to self-splint and brace. And muscles are pretty good at that, except that has longer-term consequences. They forget how not to do that. They get fatigued, and that by itself causes problems. They inhibit movement, of course. If they're just splinting and tightening, things don't move as well, and a loss of movement causes problems of its own. Further down the line, and now we're talking probably days to weeks after an injury, you have connective tissue splinting, where the CT stands for connective tissue, where the connective tissues actually start to add stability that's been lost too. The collagen fibers begin to heal, and they heal by gluing themselves back together and gluing themselves onto everything around them. The ground substance of the matrices that they're embedded in also get thicker and harder. The body starts to lay down new fibers, and all sorts of things happen at the connective tissue level to try to repair the damage and add stability where it's been lost. This is a photo from Ron Thompson showing some of the connective tissue down on the chest and the rib cage. And the shiny part is probably the hyaluronic acid ground substance, the long lines or fibers of collagen running through that tissue. And when it gets overstretched or injured or strained, it starts to get thicker and less pretty and starts to lay down tissues in every which direction. These are collagen fibers within a tendon. Just beginning to, they're aligned, but they're a little teased apart as well. And in the body, the scars are like that. They get a little more random, a little less orderly, and that changes the tissue's adaptability. These images from the Visible Human Project that Jeff Lynn put together show the continuity of the connective tissue and fascia all through the torso. The lighter layers here being the superficial fascias, the deeper ones being darker, and these envelopes of connective tissue go down through the entire body, go all the way up into the head, down to the toes, and connect every part to another part. So when these tissues get disrupted, when they start to lose their ability to be adaptable, that'll have effects throughout the system. The next in our list, after connective tissue splinting, is pain. Pain could be a result of any of the things that have happened before. Of course, it hurts when your tissue's been damaged. The muscle spasm that accompanies that gets painful after a while. Connective tissue itself is highly innervated and gets sensitive when it's been damaged and when it loses its mobility. And pain becomes its own phenomenon, becomes itself perpetuating. So there's a representation of synapses in the nervous system, right down at the synaptic level, right down at the level of the synaptic cleft. The arrangement and structure and number of the gates that control the neurotransmitters going back and forth changes when there's chronic pain. And I'm going to do a fun, I guess it's going to be fun, it's not a very fun topic, but I'm going to have fun talking about this important topic of chronic pain in a few months on another webinar. But in this case, let's just do a quick version of it. Pain makes it more likely that you're going to feel more pain, especially if you feel it over a long period of time. Long-term potentiation happens where the actual, like I mentioned, the actual structure of the synapses changes. You get more synapses along those pathways where pain is felt, if the pain is continuous or chronic. And after a while, other things, you get allodynia, things that aren't normally painful get interpreted or experienced as pain by the nervous system. So even small movements or a light touch or little balance disturbances end up being painful when someone has potentiated like that, when they're that sensitive to that kind of pain. The good news is that hands-on work can help give alternatives. It can give an alternative kind of sensation that the nervous system can reorganize around. The benign sensations of gentle or skilled body therapy can definitely give an alternative to those continuous pain cycles that can get set up when someone's been injured. After pain, we have vertigo, dizziness. Now, one theory about the vertigo that sometimes comes with people's whiplash, and not everyone gets vertigo, obviously, not everyone gets all of these symptoms, but some people do have whiplash vertigo for sometimes a long time after being injured. One theory about that is that it's the nerves along the anterior part of the neck, the sympathetic ganglia, that get stretched and injured in the hyperextension injury. There are other theories as well as to why some people have vertigo. Here's a little image of some guys changing a light bulb on top of a radio antenna, which is on top of a skyscraper. And then the photographer was on top of them, above them, Vincent LaForest. But another theory about the vertigo is that the inner ear gets actually jarred or disrupted. And here's some images from Primal Pictures showing how the inner ear is embedded in bone, and yet it senses our movement, and if it's had a big jolt or it's had some interesting postural reflex disruption, it can be signaling movement all the time, even when there's not movement. So the semicircular canals are arranged in 3 planes, and they sense movement in space in any of these planes. And if the postural reflexes aren't quite in control of the head in the same way, if you go back to that brake and then gas pedal analogy, there's a little bit of instability all the time. That's like a low-grade stimulus to this inner ear, which is constantly signaling a little bit of disruption, a little bit of sway. Imagine that antenna with a little bit of sway in it all the time. Those guys are going to be a lot less happy than if that antenna is solid and familiar. And the result can be dizziness or vertigo, and that can make people nauseous. It can make them upset, obviously. And it's a tough scene to be living in when you get to that place. So vertigo and dizziness by itself causes ANS sympathetic activation. Again, ANS is autonomic nervous system. These are the fight or flight responses. When you have these things, the pain by itself also would cause your sympathetic nervous system to be more activated. You'd be in a constant fight or flight, either a low grade or a high grade. And so people experience things like sleeplessness or anxiety or emotional upset after a whiplash injury that looks kind of mild from the outside, and yet these things going on in their physiology and their nervous system can be continuing upsetting them. And we just have a couple images here of upsetting moments in a whiplash theme. This image, by the way, is a log coming off of a logging truck. It's not someone's last picture they ever took. This is actually a photoshopped image. But the part of this autonomic nervous system activation is the result of amygdala responses. This is a sculpture, a wooden sculpture showing the parts of the brain that are responsible for perception of threat, that is the amygdala of the brain. And they tell us if we're in trouble or not. That's basically their job. If we're in trouble, they go right to our deepest physiological responses and say alarm. They say fight or flight. And that's what. And at that point, we tend to even lose choice about how we respond. Those alarm switches have been triggered, and we are in that reaction, which by itself can become a positive feedback loop. A positive feedback loop is a response that triggers more of the same. So when we have, say, adrenaline release from being upset, that actually increases our level of upset, which increases more hormone or adrenaline release, and then increases our activation and our fight or flight response until we either live at a high level of activation or we collapse, or we get to the place where it's just too much and things collapse. After autonomic sympathetic activation, anxiety, depression. I mentioned those as being sequelae, things that come after a long period of being fatigued by the sympathetic response. So people will often experience psychological or emotional responses too, related to all these things that are going on in a whiplash, even a fairly mild one. Now, I said this could be a timeline, but any of these things could happen along the way. It's not a strict timeline. It also could be an ordering of, say, structural to functional issues or objective to subjective issues. But whiplash can really affect people all along this. Either one of those axes can be things you can observe. It could be a subjective experience that the client is having, and a combination of any of those as well. Now, I want to give you this hot-cold model because that's been really helpful for me in my practice, sorting out how to work with whiplash. Because if we approach a whiplash inappropriately, we can actually increase some of those responses and make it worse for people. Hot whiplash is usually recent. Cold whiplash, on the other hand, has been typically 3 to 6 weeks since injury, although it could be a lot longer. Sometimes a hot whiplash can take a long time to resolve. Whiplash also can have aspects of both. It can have both hot and cold, particularly if it's an older whiplash. In a hot whiplash, you have pain resulting from the instability and spasm of the muscles, and you have guarded or careful movement. In cold whiplash, by contrast, you also have pain, but the pain is related to immobility and inflexibility. So it's not just a lack of stability anymore. It's actually things won't move, even if you want them to, and things get stiff or restricted. The restriction, in each case, things are restricted by the muscular hypertonus, that's the spasm. In cold whiplash, you have the fascial hardening setting in. The cement is starting to harden, as it were, and the ligaments and membranes and articular restrictions are starting to form and get thicker. The tissue quality to your hands is going to be really different in each case. In a hot whiplash, the tissue will feel inflamed or puffy or slippery, or kind of glassy sometimes. Sometimes it's soft. Sometimes it's hypertoned when the spasm is set in. Say the muscles are really tight. But it often touch is painful in that case, and deep touch is especially painful. On the other hand, cold whiplash, the tissues get harder, they get denser, as opposed to puffy or slippery. They get rigid, especially when you get down to the deepest level around the joints. And they can be, in that case, tissues can be insensitive to light touch. In that case, your body tends to crave or want deeper touch to get down to those deep levels of immobility. Our goals as hands-on practitioners are going to be different in each case. In hot whiplash, our goal is really to calm the unresolved fight or flight activation. We're going to think about hot whiplash as a nervous system phenomenon because that's primarily what is being experienced by the client, is their nervous system reactions, and primarily what we have to get past to be able to even address the tissue. If we ignore the nervous system, if we ignore the activation and just start doing work on the tissue, that can actually increase someone's emotional upset, but also their neurological responses, and they can end up with more spasm or more pain. So our first step with hot whiplash, really want to calm those responses. We do want to encourage subtle motility, and I want to contrast motility with something else a little later on. And then we also want to broaden the client's focus beyond the injury, meaning it's often beneficial to work other parts of the body and not work much, if any, on the areas that have been directly hurt for quite a while. We tend to forget that we have a whole body when part of us is hurt and think just about the part, and it'll shift someone's subjective experience quite a bit to include other parts of the body in our work, and so bring the awareness out into the whole. Now, here's some more pictures of different people and different activities that would cause autonomic nervous system responses. train with the bridge going out. This is, by the way, another Photoshop job. So it's not someone's last picture. And the motorcycle rider in the playground making the point that autonomics have to do with perception. In other words, trauma is in the eye of the beholder. If someone experiences something as traumatic, it is. Never mind how fast they were going or how far they fell or didn't fall, or the fact it was a near miss and not an actual accident. The physiology doesn't know the difference between a psychological trauma and a physical trauma. The tissue does, but the nervous system doesn't. The brain doesn't. And so anything that's experienced as trauma does have traumatic effects, including social trauma, including humiliation, being shamed or embarrassed can have similar effects. And situations like that can reactivate someone's whiplash, stress, just the stress of daily life, say. This is a call center. Overwhelm, just too much. All right, so in a hot whiplash, we're resolving those fight or flight activations. Now, Eric, we talked about you coming in. Is this a good time for you?
Yeah, sure. Thank you very much, Til.
You're welcome. You were going to talk a little bit about the conference itself, huh?
Yeah, sure. That would be great. And I also want to remind our listeners that if you have any questions for Til, then click the Ask Question button that you'll see just below the broadcast screen. Type in your question there, put in your name so we know who you are, and we'll try to get to as many of those questions as possible before the end of the presentation. And also make sure you stick around after this formal presentation is over, because Til has prepared some great video for us. It's fascinating stuff, and I know you're going to enjoy it. And while that video is playing, Til's going to go into the chat room to talk with you personally. For those of you here tonight who are not signed up for the 2012 conference, I want to encourage you to do so now. You'll have access to about 50 of the world's leading massage experts, and I say it all the time. Going to the World Massage Conference is like going to the Academy Awards night of massage. These are the superstars of massage who you've always wanted to meet, and you get to interact with most of them one-on-one through the chat after their presentations. A few of our featured presenters for 2012 include Tom Myers, Til Luchau, who's with us tonight, Whitney Lowe, Eric Dalton, Ruth Werner, Susan Salvo, Tina Allen, Laura Allen, Paula Stone, Casey Miller, Judith Aston, and I think that's only about 10 of the over 50 experts we're going to be featuring. Another benefit that registrants can get is the opportunity to take CE quizzes and print off certificates for each of these presentations. All of them are NCB, TMB approved, and there's just a small one-time administration fee to get certificates of completion for all 50 hours of presentations. We know that not everyone signs up specifically for these credits, but it's a fantastic opportunity, and these days most organizations recognize at least some online CEs, if not all. And I just want to remind listeners one more time that if you are signed up for those certificates, then just simply click the quiz button below the broadcast screen before this broadcast is over to complete that quiz and get your certificate of completion. Thank you very much, Til, and I'm going to hand it back to you.
Thanks, Eric. So we left off here. We said in hot whiplash, our goal is really the nervous system, calming the nervous system, encouraging subtle motility. Now let's contrast that with some suggested goals around tissue restrictions. We're on cold whiplash. In cold whiplash, our goal is really to release those tissue restrictions. It's time now. Usually cold whiplash is after some healing has started to occur, and yet we've often lost mobility at that point. So we start to address the tissue restrictions once the whiplash has turned toward the cold side. And our goal is really to restore that lost mobility. Now, the difference between motility, which we're trying to encourage in hot whiplash, and mobility in cold whiplash is that motility in hot whiplash is active movement. That's going to be much more comfortable, much safer, and much more measured, you could say, for the client. If we're asking the client to do gentle, active movement in the hot phase. And then we can start to do more passive movement, more larger gross releases, gross range of motion issues in cold whiplash that we're going to be aggravating and upsetting and probably not structurally helpful either in a hot situation. They're just what's needed in cold, that mobility, getting things to move again, being able to move them. In hot, we want someone to be able to move themselves. And there's been a change in the last 20, 25 years in treatment protocol. It used to be that people had a cervical collar put on to immobilize the neck while it healed. That's not really used that much anymore, at least in this country, because what would happen is the lack of movement would cause the tissues to set up and glue themselves together even more, and you'd lose quite a bit of mobility, and just that recovery process would be made longer. So gentle motion is thought to be good, even including immediately, including the day of the injury. And when you're working with people and you've seen them and they're at a recent injury, getting them to do small movements as you work in their body can be very helpful. However, if it's been a few weeks, if they're starting to get the harder, denser tissue, the pain levels are going down, you can begin to look at restoring mobility to their range of motion, essentially. Yellow light signs of whiplash, things to watch out for to let you know that trying to get mobility isn't appropriate yet. Less than 3 to 6 weeks since your injury. Tissue swelling, anxiousness, sympathetic autonomic nervous system activation, as well as sudden painful spasms, often triggered by movement. If someone gets a spasm when they move, then you need to slow things way down and have them move less. And certainly not going to be using pressure to try to release things at that point. Our strategy, in each case, in hot whiplash, we work primarily with the nervous system. We're working within a client's range of active movement, how far they can move themselves. That way they'll keep it from being too painful, and they'll keep it subtle and gentle. And we're going to address any myofascial restrictions only away from the injured areas. The myofascia hasn't had a chance to set up yet. It's still inflamed and upset, and it's doing an important healing stage. We're going to keep it happy by gentle movements that the client does, but we're not going to get in there and try to release the connective tissue of the neck in a hot whiplash situation. One of the places we might start working is the other end of the body, down at the foot, and getting the joints of the foot mobile can be a very important way to get someone back on the ground, get a sense of stability and adaptability on their base, so that the rest of the body starts to calm down, so they actually get some ground, get some floor under them. Another important place, and this is one of our instructor George Sullivan's tips, was to work at the sacroiliac joints, kind of the base of the spine, which are like the feet of the spine. So working around the hips, and particularly around the sacrum and sacroiliac joints, is a place that can be very calming for people because of the parasympathetic nervous ganglia that are concentrated here. But also it makes sure that the other end of the spine is adaptable. When, say, the upper end has been moved violently, the lower end moves subtly, can be very counterbalancing and very calming. One of our techniques that we teach for working with hot whiplash is this one, called the breath sandwich, where my hands are like the top and bottom pieces of bread on a sandwich, and my client's breath is the filling. And it's as simple as asking my client to let her breath move between my hands. And it sounds simple, and it is simple, but the effects can be very profound, especially if someone's in an activated or aggravated phase. This can be done sitting as well, and sometimes sitting is a preferred position for someone that's had a recent whiplash or other kind of injury. Sometimes just lying down can be activating. But just with one hand in back, one hand in front, ask your clients to gently feel the breath between your hands. Now, the idea isn't to force the breath between the hands, but to allow the breath to move gently between front and back. That focused attention to breath brings a parasympathetic response and starts to calm the nervous system. It also helps that subtle motility, the movement being caused by the client's breathing, that allows the tissues to stay mobile and free. So in cold whiplash, our strategy is to work with myofascial restrictions and movement barriers to restore mobility, both locally, where the injuries happened, and globally throughout the body. So it's time to work with those restricted tissues. Like we mentioned, the back of the neck when the head has been thrown forward. The tissues, the transversus spinalis and erectors and other, in this case, sternocleidomastoids, in this picture, nuchal ligament, when that head has been thrown forward, they could have been overstretched, and once the hot signs have settled down, those yellow light signs have settled down, it can be time to start to do some direct work with the connective tissue. Not one of Ron Thompson's great connective tissue pictures, showing the bonds that happen between the fibers, the bonding that can happen within the tissues themselves. It's time to actually start to free some of that, as well as getting down right to the ligament, say, the nuchal ligament I mentioned, also the ligamentum flavum, right around the spine, the capsules of the facet joints, all these things can be bound up tighter, harder after a whiplash. In one of our techniques here, the transversal spinalis technique, I'm using a soft hand on the table, my right hand in this picture. The first knuckles of that are gently hooked into the tissue on the back of the neck, and then I use my left hand to lift the hand, or flex the neck, to gently drag the tissue underneath the knuckles of my right hand. It's a very gentle technique in spite of using the knuckles, and it lengthens and frees up and differentiates the layers of the connective tissue throughout the back of the neck. I believe that at least a couple of these techniques are illustrated in the video that's going to be shown after the call tonight. Right down at the ligament level of the neck, the base of the neck, there are ligaments underneath the scalenes that surround the brachial plexus and cervical nerves and can cause neurological symptoms, nerve compression symptoms down the arm or into the shoulder. And in these cases, these are the costopleural and transversal pleural ligaments, the ones that suspend the top of the lungs. The lungs are essentially suspended from the cervical vertebrae and from the upper rib with these ligaments. And so breathing is another way to start to get down to this deepest level. And we can actually do some gentle work deep in the neck to work with these ligaments, again, once the hot symptoms have started to calm down and release. In this picture, the facet joint capsules are colored green. This is a Primal Pictures image. And the purple arrow represents some translation movement of the vertebrae. And you can use that movement gently with your fingertips, holding the whole head and neck as a unit. Again, this is cold whiplash. This is not hot whiplash. To translate the neck sideways and feel, does each vertebrae glide gently left and right? If there's a restriction to the glide, it's likely due to the facet joint capsules or the ligaments around the vertebrae. And so encouraging more translation in the direction it's not going can help gently release those restrictions and help the body accommodate a new kind of movement in a direction that's often been lost. A helpful metaphor in each case: when you're working with hot whiplash, you can imagine you're working on a bare nervous system. You're going to use slow, delicate, gentle touch. It's like working with an unprotected animal. This is a baby macaque. These are baby hedgehogs. You're going to touch in the way you would touch a baby, an unprotected nervous system, or a bare brain, the way you would touch that, because essentially that's what your client is experiencing. The usual filters, the usual protective mechanisms are not in place. And you're going to go slowly. You're going to go drop by drop, as it were. This titration model that's used in trauma work, where you do a little bit and you see how someone responds. If you do a lot, even if it's a lot of gentle work, it can be too much, and you won't catch it until the client has had a backlash, until they've had a response afterwards. So do a small amount of work. If you're doing a timed session where you're responsible for doing a certain amount of time, do work elsewhere in the body and just do a little bit, starting to get closer to the injured areas, and see how they respond. If they do well, fantastic, do a little more next time. If they're more stiff or more sore after your session, back off, go the other way. So the metaphor we use in cold whiplash is imagine melting something. Imagine melting, say, a glacier with the warmth, pressure, or patience of your touch. So because things have set into place, because things have gotten into that cold phase and gotten harder, we actually want them to soften again. You could say they're too soft in the hot phase, not soft enough in the cold phase. So by patience, by pressure and waiting, we get things to soften. Now, as a review question, I want to ask this one: which of the following can aggravate whiplash? If you want to go ahead and type this into your chat box, I can see some of those, and you can get to see some of your guesses too. Which of these can aggravate whiplash? A, pace of the work. B, depth of pressure. C, the length of the session. D, proximity of touch to the injury. And then E and E and all of the above. What's your best guess? What do you think? Type a couple things in there. I know there's a little delay there, but I've hopefully spoken long enough to catch that. We're getting a lot of E's there. Yep, a whole lot of E's coming through. If you haven't typed in E, go ahead and type in E. That's how we know. Yeah, it's E. These are all things that if you don't pay attention to, you can actually aggravate whiplash. If you work too fast, you work too deep, you work too long, or you work too close to the areas of injury. All those things can start to begin to worsen things instead of make them better. And they're basically signs to back off, to take your hot strategy a step backwards and go even slower, go even farther, go even lighter, go even shorter. Because body work can be helpful or it can be aggravating, as this picture illustrates. And I don't believe that this man's pectoralis major has actually been pulled out of his body. I think this has been painted on the negative. But body work can be too fast, too hard, and cause a traumatic reaction that maybe the tissues benefit, the intention rather for the practitioners, the tissues benefit, but the nervous system may not in this case. While if we take our time and really work at the client's pace, like this picture of Ida Rolfe, the founder of Rolfing, working with a little one, a baby, like she's demonstrating, you can work pretty deep. If you see her fingers, they're pretty deep in that baby's pectoralis major. It's like in the last picture, but a very different connection happening between the practitioner and the client, and a very different response. And then finally, this picture I always love showing this picture because it shows Warsaw, 1947, a couple of years after the end of World War II, totally devastated city in the winter, bleak. And yet this guy, this photographer, has set up his stand. He's taking pictures of people for money in front of a background, a cloth background with a chateau painted up on green forested hills. And you can come and have your picture taken in the midst of this bleakness in a green and verdant place. And that's something like the nervous system. That's something like we do around injury. There's always a place in there that's green and hopeful, a place that knows things are going to get better. And that's the place we work. That's the place we look for in our work as we do whatever it is we do with our clients. Now, I should thank Primal Pictures for the anatomy images they provided. They do great work, and I've supported our work quite a bit at advancedtrainings.com. And then we have some offers for you. You can get a mini manual if you subscribe to our newsletter that includes the techniques I mentioned and a bunch of other ones. And it includes the ones that are shown in the post-presentation video, the ones that's going to play next. It has a link back to the World Massage Conference and to our own optional CE credit or certificate, as well as a transcription of the webinar audio. There's a $15 off coupon code there. 15% off. You can get off of our myofascial DVDs or our 1-hour certificate programs or our manuals, etc. And there are special offers from our partners like Primal Pictures and Body Cushion. That's the link to check out, advanced-trainings.com/WMC12W. Or give us an email or call. Be happy to help you out.
Okay, thank you very much, Til. I've just posted that link in the chat room so you can click on it to get to that page directly. So as you've been going through your presentation, which is fantastic, I love your slides. I can't believe a sculptor has actually sculpted an amygdala.
An amygdala, yeah.
Fantastic. Fantastic slides. Well, you've been doing your presentation. Scott has been taking listener questions, so I'm going to hand the mic over to Scott, and he's going to try to keep you on your toes by throwing some of those at you.
Great.
Well, I've got lots of questions. I've had to work really hard tonight, Til, so keeping up with everybody's questions. Til, let's start with, where did the concept of hot and cold whiplash come from?
You know, that came from my own observations of what the tissue felt like as I was working with it. It's sometimes the hot whiplash will actually be hotter, puffier, inflamed. Not always. And sometimes a stiffer, denser whiplash that's older actually feels a little less hot, colder even. So that was an easy metaphor to think about all these different things. And it's not quite acute and chronic, although it has those dimensions. There's some other ones in there as well. But hot and cold is just an easy metaphor to remember the differences between the two.
It really seemed with your presentation when you were talking with hot whiplash, your goal was more to calm the client and relaxation and have them more of a trusting relationship between yourselves, that you weren't going to hurt them any further than what they experienced in their accident.
That's really a first step. Just establishing that safety, establishing the relationship there, establishing that someone can be in their own body, or can relax, be on your table. They can just settle in a little bit. is a step toward resolving that hot whiplash sign. I should mention, too, that you can send a whiplash back into a hot phase by working it too aggressively. Even after it's gone to the cold phase, if you work it too hard, you can send it back to hot. Or there's people that will cycle back and forth, too, as a natural course of the healing.
So do you find it difficult sometimes when you're working with a client or trying to convince them that when you're working on another body part other than where they're feeling this discomfort to say, listen, I'm going to work on this area to help relax you? Or do you see when you have a really acute client come in, they don't want you to touch them anyway?
Well, you see both, of course. There's people that say it hurts here, work here. And then there's people that say it hurts here, but work anywhere else but here. But those are all important conversations, and that's really how I view it, as opposed to me trying to run my agenda or convince my client of anything. I may have an idea of what's going to help, like I just presented in 40 minutes of my ideas about what could help, but I'm really going to explain that to the client and get their explicit agreement to at least give it a try. They're saying they're coming in the day after an auto accident, their neck's tight. They're probably not going to say work deep on my neck, but if they were, I would say, well, let's try something else. Are you okay with that? Let's try this first and see how that feels.
I had a really
nice,
really
good
good
buy-in.
Oh, sorry, I didn't mean to interrupt.
No, that's okay.
I had a really good kind of second part to that question. Sarah from Eugene sent a question, and she said, I understand you working on, say, the SI joint or the feet, but how do you justify that when you're, say, working on a motor vehicle accident client and you're trying to report this to an insurance company to approve payment?
I'm not an expert on working with insurance companies. So I'd be curious about people that are chatting in and maybe giving us some suggestions on that. I know it's not too hard with a client, and I know there's probably ways to do it with insurance companies too. It's a legitimate way to start to address the effects of whiplash. The clinically documented effects of whiplash include a lot of the ones I just gave you. And, the location you work is probably secondary to your therapeutic goal. And, reducing autonomic activation after whiplash is a very appropriate therapeutic goal for a massage therapist.
Well, massage therapists now, you were talking about some of this work that you're doing. It's very technical work and how we're explaining it to our clients. And then again, of course, if we're having it funded by a third party, we have to explain it to them. You look at the modern massage therapist has to be an expert in a lot of different areas. So we're in a very interesting field.
It challenges us to communicate, both with our clients and I suppose to know how to play the insurance game or just to talk about things that the insurance company will support.
When you're talking about the hot and cold phase, do you regularly use hydrotherapy even just for the I don't even want to say even because relaxation is so important, but just using the hydrotherapy as for the relaxation effect, and then also giving it to clients as home care?
I don't. That's not my area of expertise, but I know there's some really good work being done there. It can be a very useful tool.
Have you seen, I know it's become very popular. I have Candy from Kansas City asked, what do you think about kinesiotaping for whiplash? Again,
you're asking me great questions that I want to go learn more about. That's not my area of expertise. I can imagine that could be really helpful. Kinesiotaping, as I understand it, both gives some support, some mechanical support, but also activates proprioceptors in a way that we feel our own writing sensations more acutely, and so can respond to them more appropriately. And I can imagine both those things being really helpful. But again, I don't have any background in that, so I'm not able to really answer the question.
One specific point during your presentation really interests me because much of it did, of course, but when you're dealing with people that have suffered a trauma and specifically been, say, in a severe motor vehicle accident, they are dealing with a lot of different stressors, specifically those people that have been in an accident and maybe aren't able to do their activities of daily living or potentially aren't being able to work and don't have income coming in, and they have a lot of other stressors besides this physical stress. How do you work with that with a client?
It depends, again, on your style, on your relationship. I tend to focus on giving the client some room to speak, to check in, say, how are things going? And sometimes that's plenty. Sometimes people will take that as a sign of support and use that time with you to really get the support on that level. Other times, it'll be more on the silent level of the flesh. We're just holding the tissue in the body. Just inviting someone in can be really calming. Silent level of the flesh is a term that Ida Rolf used. But that's where a lot of body workers are comfortable working, because that's where we live too. That's where we live in ourselves. But it's sometimes just understanding, Scott, that there are a lot of things going on for somebody, and essentially believing them. Because a lot of people get met with having to justify their own experience to the insurance company, say, or to other professionals they've seen, or to their family, which is still expecting things from them, and may not understand that all you did was have a fender bender. What's going on with you? And there's lots of stigma around the whiplash ambulance chasing that kind of falls on someone's shoulders when they've been hurt. And maybe there really are deeply upsetting things going on for someone who's had a very small, from the outside, very small injury. We can help them a lot by just believing them.
I think that's a fantastic answer, Til, because my years of working with motor vehicle accident clients is really they want someone to listen to them. And pain is such a personal thing. And it's sometimes difficult to explain that to people, is that every single person experiences pain in a different way. And
you're making me think. Sorry, you're making me think that that's what we're doing with our hands. We're listening with our hands, and giving someone the experience of being listened to with our hands. I mean, it's poetic, but there's something very tangible about it. When you get that the therapist is listening to your body, that by itself is relieving.
I had a question from Geraldine in Unity, Saskatchewan. So we actually have people joining us on the broadcast tonight, Til, from New Zealand, from Australia, from countries in Europe, all across the United States, and from Canada. So welcome, everybody. You're a very big draw for us this evening, Til.
Fantastic.
Her question was: do you ever use any emotional release work when you're working with whiplash clients? In my practice, my training was as a psychotherapist, as I trained as a body worker. So I had both kinds of practices going for years, and still do. I don't advertise as a psychotherapist anymore. I work now more as a coach. But I make room for that if someone's having an emotional response as part of the work. I'm not trying to evoke emotional response. And my model actually around emotions is not a release model, to tell you the truth. Release can be helpful, but that's not all that's therapeutic about emotions. Sometimes just acknowledging that emotions are part of the picture is therapeutic. It's that listening process again. Sometimes just giving them some room or some acknowledgement. Well, trust the kind of wisdom of the organism to do what it needs to do around the feeling. So I'm not necessarily judging the success of my sessions about how emotional someone gets or doesn't get, but I'm certainly allowing that possibility and understanding that may be some people's experience. And if it's not, that can be just as valuable too. What I really noticed about how your treatment, when you're talking about how you treat and how you're working with the clients, it really reminds me of Stephen Covey when he speaks about so many of us when we're in a conversation with people, we're working on our answer before we listen to people, what they have to say.
Yeah, we listen until we know what we would be saying in that situation.
I think that most people would be very lucky to have you as a therapist, and I know certainly that took me a long time to kind of get over my own ego as a therapist about thinking about what that client needed instead of letting that client, tell me what they wanted. And that takes a while.
It does. You're saying nice things to stroke my ego here, but it does take a while. I'm still learning it, to tell you the truth. Next year will be 30 years, and I'm still, after a session, I'll just reflect and say, okay, I missed that one. That was a place I could have listened even more. And there's always another level to go, for sure.
When you're talking this, I know that you gave us some timelines, but just to review, when we're talking hot and cold,
Yeah.
Do we have a typical timeline on how long it takes in each area to typically to move a client through?
There's so many variables, as you kind of said, how strong the injury was, how what kind of health someone was in beforehand, what kind of activities they've had since, what kind of support they have in their life, how easy they've been able to take it. So there's so many variables in there, it's hard to say. But it's probably pretty safe to say that less than 3 to 6 weeks, it's not going to be cold whiplash yet. If it's been less than 3 to 6 weeks, it's still in the hot phase. There's still tissue inflammation, splinting going on. The connective tissue is just starting to harden at 2 to 3 weeks. And really you're not seeing the immobility that the connective tissue response causes until 3 weeks and beyond, at least in a way that is in balance with the hot responses. They're starting to calm at that point too. But that's a very rough guideline, because it can be, as I mentioned, it can be much longer that someone's in the hot phase. Or, there's situations where someone's ready for some mobilization earlier, but we find that out by assuming they're hot, working with them in that way and seeing how they respond. And if they respond well, then we can start to trickle in some of the cold approaches.
Well, Til, this has been I know it's been a great learning experience for me tonight, and for all of the people that joined us online, and for all those people who are going to have the great opportunity to be able to listen to this broadcast over and over again. So on that note, I'm going to turn it over to our host, Eric Brown. Eric?
Thanks, Scott.
Thank you very much, Scott. And for our listeners, if you've been enjoying this presentation, hang on, because it's not over yet. There's some great video to come.
Technique number A2. Is that right?
Yes.
It's the talatibial joint release. And as we mentioned in the lecture, we start working with whiplash here at the periphery. You could start other places in the body too. This isn't the one place you have to start with hot whiplash. But we start working with it far from a point of any injury. And we're picking the talatibial joint in particular because of its intimate relationship with postural reflexes. I mentioned that there's a lot of weight transmission through there. It's a very small point of contact that has a lot of weight through it, and we balance on those things. There's a lot of sensors, proprioceptors around these joints. And when I lean on it with my ulna here and my hand under the calcaneus on the other side, it puts a different kind of impulse, different kind of input into it than it's used to. So I'm kind of encouraging that tibia to drop backwards.
Is that the one that has a tendency to go out when women wear super high heels?
I don't know. I haven't heard of that. There's lots of things that come with super high heels, but I haven't heard of a talatibial issue. It could be, though.
So you don't want to bolster at all under the knees at this point?
You could have a bolster under the knees, yeah. I typically don't work with one because I find that it immobilizes the body in a funny way. Mm-hmm. But if someone prefers it, I'll follow their lead on that for sure. Yeah. So I just wait. I get on the tibia with my ulna and I wait for it to drift. I'm not pumping it or pulsing it or scrubbing it. I'm just waiting. How's the pressure, Dana?
That's great.
Okay. And we're thinking autonomic response. We're letting her brainstem register this different kind of impulse and letting things calm. And I mentioned that people can get spacey or even start to doze sometimes from this place. We're having this place worked in this way.
Is it important to share why you're working down there with your client?
If your client comes with a whiplash and they're pointing to the neck, yeah, we want to have a conversation about our strategy overall. Absolutely. Make sure they're on board with why I'm doing that. Yeah. Okay. The next technique, and that was short, by the way. I'm kind of abbreviating it for the demo, but you might wait longer until you feel that melting or you feel those big breaths coming in, those kind of things. What's the next technique? Oh, question about that one?
You would do both?
Yeah, thank you. Both sides, left and right. Or three if they have 3 legs. Or SI wedge, give me the page number again if you don't mind. A3, that's right. So after working with the lower end, we're starting to work up the body. You might take a lot more time than just these 2 techniques, obviously, if it's a recent whiplash. But another place that's important to work, as we mentioned, is the SI joints. And in this technique, I'm going to get under the sacrum and lift into the sacrum with my fingertips from the back, while the top hand feels the ilia's position and its resilience between the 2 hands. It's a very gentle resilience, though. I'm not pushing down on the ilia, but more listening with this top hand as I lift gently under the ilia. It's not a lot to look at someone do, you know. That's about what it looks like. But we'll show this on the skeleton too when we get one here. We'll show that to the camera and to you guys as well. But I'm just medial to the PSIS on the sacrum itself, on one side of the sacrum, lifting into that sacrum as I let the ilia drop backwards. And this also has autonomic impact. We mentioned a bunch of parasympathetic ganglia around the sacrum. So this tends to be calming, and it was great when there's the hyperarousal for hot whiplash too. Technique A4, thank you. 4, it's roots of the arms, we're calling it? What's the title, full title? Yeah, lower arms, roots of the neck. Okay, roots of the neck. The arms, especially the forearms, could be thought of as the roots of the neck. A lot of dynamics that happen in the neck will be reflected by what's happening in the arms. Also, the adaptability of the neck will be influenced by any restrictions in the lower arms and the forearms. So as a way of working this peripheral pattern around any specific injury, we're going to work the forearms too. And here I'm using the ulna again, not the point so much, but the ulna to feel into, to feel into the flexor compartment of the arm. And I'm imagining that this core of the arm, that almost the interosseous membrane between the bones, extends all the way up into her neck. It does. There are anatomical connections all the way up through. But I'm almost feeling the neck up through the center of the arm here. Now my pressure is firm, and although I even mentioned the interosseous membrane, I'm not trying to dig down to that level, more like feeling through these tissues that I have a hold of to feel that connection. How's the pressure, Dana?
That's good.
And my pacing is slow, waiting. I am sliding a little bit, but it's not a repetitive sliding stroke. It's more waiting for her tissue to respond. And this reminds me of snake charming. So I heard this, the snake charming isn't the music that the guy's playing with his flute or woman, whatever, whoever's the snake charmer is. It's the movement of the flute. You charm a snake by the movement. So at this point, it's the lack of movement, it's the very slow movement that's calming that nervous system. If I'm, doing a bunch of deep stuff, that's raising your autonomic activation. This waiting or feeling on my side down through the center of the arm is part of what calms things.
Do you only do the flexor side?
As a way of making sure that the arms are free and clear, yeah, that's about all that we need to do. If it's an arm session, we'd obviously be doing more. But in this case, I can feel right through the core of that arm just from the side. How you doing back there? You okay?
I didn't hear how you finished your last sentence. You can feel to the core of the...
I'm feeling the core of the arm.
Oh.
And I'm feeling through it up into the neck. I'm imagining a situation or picturing or feeling a situation where the core of the arm connects to the inside of the neck too. Almost like roots.
If you find you have a lot of resistance with that.
Yes. Resistance right in the tissue, you mean?
Yeah, well, like for body movers, I know that would be terrible.
Oh, yeah, because the arms get...
If you can't feel down to that level,
Yeah.
What would you do?
So the question is, if I find tissue resistance here, like body workers get, arms get pretty thick, what do you do if you can't feel down to that interosseous membrane level? I go up against the edge of whatever resistance I find in the tissue and just wait there. Because I can connect, I can use the dense tissue to connect through too. I can use that to feel into the core width. It becomes an extension of my elbow in a way.
And then for somebody that might have like not super smooth arms, is lotion okay to use?
Is lotion okay if this
For guys specifically?
It'll be harder with lotion. It'll be harder with lotion. This has been a great disadvantage I have compared to my competition. I don't get lotion sponsorship very much. But the lotion will cause you to slip on the surface. And I want the friction to be able to feel down into what's happening.
What if someone says that it's, too uncomfortable, it feels like it's tearing on their skin?
I go slower. I wait more. Because usually that's the friction, the glide, and I'm not gliding so much here, I'm just waiting. Great questions. Spine rib cage release, AP rib release is called, and the page number A5. We talked about how the ribs articulate with the spine and how part of the unwinding of the whole pattern could be working in from the periphery to include ribs, since they're part of the spine's periphery. So the ribs articulate with the spine by coming in front of the transverse process. Here's a transverse process, here's a rib. The rib is anterior to that process in the back. And so if I want to release that juncture, some anterior pressure on the rib will lift it off of the TP. So I feel the ribs in this technique, find the ones that are the most prominent or the firmest, and then I gently lift that rib off of the TP from underneath. To release the rib from the TP, we're going to lift anteriorly on the rib. When someone's lying on their back, feeling the most prominent rib or the most rigid rib, we lift it off of the TP and wait for the release. At the same time, in front of the body, I felt around for that same rib. Now, the rib is lower in front than it is in back because of the angle of the ribs. And I'm going to find those ribs by lifting from underneath and feeling where that rib pokes up into my hand in front. So I get that rib between my two hands, front and back, and I lift and back while I squeeze gently in front too. So it's almost like narrowing the horseshoe shape of the rib. Lifting it off the back, and squeezing in front. Sorry, Lynn. What was?
That's right. Is that different than unwinding?
Then I unwind. There's two steps. Well, three. One is the assessment, finding the rigid rib. Two is the compression. Three is the unwinding or release. How are we doing, Dana? So I get my hands right under, and feel free to move around. Sorry about my back, everybody. I'm assessing this whole left half of the rib cage and feeling, are those ribs resilient, or are there some that are particularly fixed? And there's something right in this region, huh?
Right.
So we're kind of T6-ish, somewhere in there, T5, perhaps. And so I've lifted now that posterior rib forward, anterior in the body, and now I'm going to put my hand here in front, and as I lift and back, I'm going to feel where does that rib poke up into my hand in front. And I can feel it lifting there at the costal arch a little bit, so I get in the front of it, and I compress. Pressure's firm. I'm feeling for bony movement. There's lots of little connective tissue or muscular tightnesses around the ribs and back, of course. I'm ignoring those for the moment and just lifting the bone and then waiting for it to start to move. And her breath certainly moves it, so I allow the breath movement to happen, and there may be other movements as well that it wants to make. There may be kind of a bucket handle kind of motion or an in and out kind of motion, but I just follow its motion while I hold it in this compressed state where it's free in the front and free in the back.
Compressing on the back only, or compressing more on the back?
I'm squeezing from both the front and the back, about equal. Although it's easier from the back because she's lying on it, And so my hands are following that rib motion. Now the front's moving down a little bit. And I just follow and wait, still compressing in a comfortable way. And the breath is coming back in. Until I feel things release, soften. Yeah. Doing okay there? Mm-hmm. Any comment about that?
No, I mean, I could definitely, it was tender at first, and then by the end it was already a lot softer and more comfortable.
Less tender. Mm-hmm. Great. Any questions?
You have in the notes, it says for whiplash, be sure to release ribs 1 through 3. Is that prior to this?
Oh, no, as a part of this process, yeah. Thank you for reading that note to us. The whiplash, especially if it's a neck injury, will involve those upper ribs for sure. And that same principle, but I'll be able to do it easier from up here, obviously. Just feeling those top ribs and making sure that they are relatively free. Now that's getting a little bit into the cold whiplash idea. That may not be something to do with a hot whiplash. We may not even get this close to a recent injury. Thank you. Vestibular orienting release. Vestibular orienting release. Page number? A6. This is recycled from our neck workshop, as you see. But here we'll give a special attention to the trauma implications of this, because that's what we're talking about with hot whiplash. The mechanics of the technique are really simple. It's just, how you doing there, Dana? You're great. Okay. Lifting the head till I feel a moderate stretch. It's not a stretch of the neck, but I do start with it lifted, and then I lower slowly enough that I can feel, and she can feel, where she might hang on to the head. And I described those little moments of hanging on or something tightening as mini activations, as tiny little moments of autonomic activation where there's a bit of uncertainty or a habitual holding, or it could relate to a position that was injured or a place in the neck that's been injured. When I find one of those places where her head seems to get lighter in my hands, or I can feel her holding on, I just wait there. I just wait for her head to release. And so this could take some time. So it's important that I'm comfortable in my chair, that I'm letting the weight rest on the table, as opposed to trying to hold it all up with my muscles. Yeah, my wrists resting on the table under there.
Are you right up on the occipital?
The grip, let's see if we can view that. Move your head, I'm sorry. I'm just got to hold comfortable. Whatever grip is comfortable for you. I think it was pointed out yesterday, I'm doing it differently in the picture than I'm doing it here. Two-handed grips possible. The grip isn't crucial. It's something comfortable for you so you can take the time to lower it slowly. So it's important that I'm comfortable in my own body too, that I'm able to monitor my own relaxation. Now, if someone's neck has been injured, we want to be really delicate with moving their head around. And a general rule of thumb that this technique already violates is with a hot whiplash, you use motility, meaning their ability to move, as opposed to mobility, which is your passive movement of them, or their ability to be moved. So movements that you can have them make are generally much safer than movements you make for them. The same principle holds true for other kinds of acute injuries too, or disc injuries too. You know, those kind of, that principle really helps keep you safe. Doing things that involve the client's movement, they're not going to typically push themselves into places that are too painful. And the movement in whiplash, in the case of whiplash, is really useful because it prevents adhesions and keeps the tissue fluid and healthy, and also starts to reestablish those reflexes. Back to the technique though, all I'm doing here is just waiting for her head to get heavy again. But again, if the neck was injured, I'd be really careful about the lifting phase. And I would be in touch with her on the way down about how she's doing, especially for any dizziness or vertigo. How are we doing, Dana?
Great.
If someone did get dizzy, I'd back off a little bit from that position and just wait for that dizziness to subside. And we can even start a signal system that says, go ahead and just raise your index finger when you feel the dizziness subside there. We'll just wait. And so it might be 4 or 5 breaths, and she lets me know with her finger, and then I go touch more. I might say, raise your finger if it starts up again. And I can actually feel someone start to grip a little bit with their head, tiny bit. So you can do that kind of dialogue with someone too. It's really rich. Questions?
Would you use the information you gain from that, where they tense up, to inform any later techniques, or?
Yeah, yeah, you could. Although it may not be really literal. I don't have a chart of if it's this degree of angle, it's this part of the body or something, right? But yeah, that's going to indicate something's happening there that could be interesting to explore in other ways. Yeah.
Are there any warning signs? Like, they're supposed to go see a doctor first, right? I mean, are there any warning signs? Because I know that they're misdiagnosis too. Like, if you have something on the table and our doctor said it's okay,
right.
Is there anything we should be looking for to make sure that we're not?
Yes. The question is, are there warning signs or things we should watch for, whether or not their doctor says it's okay? There are a list of those things in the back of the book here, and we'll stick that in the video somehow. Briefly, if someone gets nauseous, that's not good. If their eyes wiggle, that's not good. Well, I don't know if it's not good or not, but it's a sign to be careful. Or if they vomit, stop working on them, you know. Those could be, not necessarily, but those could be signs of spinal cord compression that could come from a ligament compromise. If the ligaments got sheared off or torn, then the bones could actually push on the spinal cord and cause some of those things. It may not mean that too, but those are things to watch out for, and they're listed various places in the notebooks.
I took a class, it was a really mild class in orthopedic massage, and he used to have us press down on the top of the head first, and if
do a little compression or something?
Then you could continue, but if they had any kind of dizziness or weakness going on, then you weren't able to work on them.
Interesting. I haven't heard that test. That's interesting. It's intriguing. Yeah. In general, I'm thinking release, and especially if someone's unstable, I'd be very careful about how I'd push down and all that kind of stuff.
Yeah. I was thinking the guy was Whiplash.
No.
So often I find it's the injuries aren't really diagnosed. I mean, it's kind of iffy whether, so they have whiplash, but that's, a kind of a big term.
It's a big term.
And often there's no MRIs or there's no even X-rays if it's mild. And so it's kind of such a vague thing.
It is a big one.
And the MRIs don't come until later if things don't get better. And
great.
So it's
true. There's lots of clue going on. We have to keep our eyes open for sure. A7, acute injury technique. This way of working can be used. I actually learned it with ankles first, but you can apply it to anywhere in the body. And the principle is that when someone's been injured, there's a vector of force, that they got injured in a direction or a combination of directions. And often their movement, their passive motion, will be greater in that direction of force. Think about an ankle. If the ankle gets twisted in one direction, it's probably going to be easier to move that direction later. So here we are breaking our rule about mobility again, but we're going to be super gentle, because what I do is I take a hold of her head and I test her mobility. The rule that I mentioned, by the way, is that we use motility, her ability to move, in preference to mobility when there's a hot whiplash. But here I'm just being super gentle, and I'm testing motion in each direction. I'm sliding a little bit this way, I'm sliding a little bit this way, feeling which way is easier. And it's millimeters, it's not inches. It's just tiny little bits. And then I lift and I drop, or I'll even, side bend a little bit, and feel which direction out of all those three combinations, 3 dimensions, is easier. So let's check it out for Dana. So a left side bend is definitely easier than a right side bend. Does that match what you're feeling there too? And check it out with your client too, because they'll be sensitive to it. They'll feel it. This shouldn't cause any pain. And a left translation is easier than a right translation. Sliding to her left. And flexion is easier than extension. But the clearest one was this left side bend. I'm sorry, it's a right side bend. Is that what you were feeling, Dana? This is easier?
Actually, I think
you think you felt the other one? Okay, so this is an interesting moment where we renegotiate. what she felt and what I felt, because they don't match. So let's see. Let me recheck. So you are feeling that to be easier than that, you're saying? No, you're not sure either.
Can't tell.
Yeah. Well, let me just go with what I feel, and you tell me if it feels okay.
Okay.
If it doesn't, you be sure to tell me that.
Yep.
Because I still feel that right side bending is just a touch easier. But I'm going to combine it with those other movements too. In a micro level, I'm doing very small release. It's almost like an unwinding technique of the head, except that I'm feeling for the easiest motion. I actually am moving her a little bit.
Are you moving her into the easiest motion? Or
Yes.
you're just
Going into the easiest motion. So it's like indirect technique. As opposed to trying to stretch her into the other way to make it equal, I'm taking her into the direction that's already easier.
So you just keep moving her back and forth in that easy range of motion?
I tested in every direction, but now I'm just a slow, steady movement into the easiest direction. And I wait. It's not much. I just take her enough into there that I wait. And if there is an injury there, it's often much more clear to both of us than it was here with Dana. If there's a recent injury, it can be really clear. How are we doing so far, Dana?
For a reaction, or are you waiting for a release?
Hang on just a second there. How are you doing there, Dana?
It's good. I can feel somewhere in there there's, a holding, but I can't quite identify where it is.
Okay. So, Jamie, your question, what was that?
Whether you're waiting for like a reaction or a release of some kind.
I wait for an autonomic sign.
Like a sigh?
Like a sigh. Yeah, like a sigh. Like a sigh or a eye flicker or a twitch. Sometimes people will twitch at those moments. Or sometimes they'd get really still, almost like a pause in the breathing. And a signal of autonomic shift. There's a state change. That's what I'm looking for. Now, if I feel like I'm pushing it, I'm going up against a barrier. That's not what the technique's about. I'm just taking it in the direction of easiest motion and waiting for her to accommodate around that. And then once we get some response, then I'll gently retest. And often movement is easier in every direction after that. How are we doing, Dana?
Nice. That's good.
Feels good.
So may I ask, did you have, is it just broad contact or did you have specific?
Yeah,
It's just
it's a big, whatever is comfortable to hold and test the head in a supportive way. And it's because this technique is useful for someone who's really painful. In fact, you can do it in a chair. If someone's so painful they can't lie down, you can do it seated. If you have a massage chair, you can do it that, but even just a normal chair, or I suppose even standing, but sitting is nice. You can just support the head and test very gently and just take it a few millimeters in the direction of easiest direction and wait for that autonomic accommodation, because that's helping the nervous system calm and adjust to the strain. I don't know exactly what's happening. I actually learned it as the Chinese release like 25 years ago. It was like this Chinese ankle technique is what it was, for twisted ankles. And so we would take it into the easiest direction and wait, and I don't know exactly what's happening, but somehow my model is that the nervous system accommodates this thing that's been a sudden movement and it gets to readjust to a supportive touch in that direction, as opposed to having to try to pull itself out of that. We've got a couple questions there. But hang on a second, Jamie. You had one, man and Jenny, you each had questions there, yeah?
Okay, so you took her into flexion and extension. You took her into side bending with us?
It's all three directions: side bending, flexion, extension, and rotation. Thank you.
That was my question.
Rotation. Jamie, you had a question?
Well, I was just wondering if it might be, if you have a sudden, let's say you twist your ankle or something and then you move it into that direction, it's easier to move. Maybe slowly moving it into that direction might be reminding the body that it is okay to go that direction.
Nice.
Kind of maybe re-educating a little bit.
That's right. In a innocuous way, so it's not painful. Yeah.
It's interesting now because I feel like all the little intrinsic muscles want to kind of unwind. Like they want to do little movements that I wouldn't have even noticed before.
The subtle work is really great for hot whiplash because it does wake up those intrinsic small muscles around the joints. So it's to get them reactivated. Are there more? That's it.
That's it. That's it.
That's it for a hot sequence. The other thing about hot we didn't mention in the slideshow I should mention now is the big danger with hot whiplash is overworking. You know, it's easy to want to do too much. And an hour session might be too much. An hour and a half is probably, for sure, too much for someone with a recent whiplash. Even if you're working elsewhere in the body. Because they've just had too much input. And you don't need to keep, adding more to it. So shorter sessions with that, initial injury. Half hour perhaps, or,
Yeah, I told them half hour.
Yeah. Yeah. Any questions at all?
So how many days a week?
How many days a week? One or two?
Some kind of overdoing it.
Yeah. Some people want to come back, especially if what you do helps. They'll want it as soon as they can again, but they need that time for it to settle. So, I mean, the general rule of thumb for this kind of work is 2 times a week is probably toward the max, yeah. And generally once a week is about where we settle.
And this would be in the most severe, some of the more severe cases versus the milder cases.
Yeah, although that rule of thumb would probably apply to milder cases too. That it's easy to overwork someone, because if you do too much, it pushes them back toward the activation phase.